It has been estimated that 50 million people in the U.S. suffer from sleep apnea. That's a lot of people. Really, the statistics aren't very good. Every time I pick up a magazine article, it's a different statistic. Some 18, some 40, some 50. I talked to a pulmonologist in Reno, Nevada the other day, a couple of weeks ago, and he told me that he feels that between 15 and 30% of the population of the United States has obstructive sleep apnea. Many, many cases undiagnosed. The first patient is Jim, and he's 58 years old, and he's 6'1", as you can see in this photo here. He's in excellent condition. He's 6'1", and he's 175 pounds. So he certainly is not obese. He's in very good physical condition. He's got a nice small neck. Anybody that's got a neck over 17 inches is predisposed to having snoring and sleep apnea. But he's got a physiologically narrow airway. So you can't always judge a patient by their appearance. Granted, you think that the big patient, like I just showed you, that 350-pound dentist with that big neck, he is certainly more likely to have sleep apnea and snoring problems than most patients who are 175 pounds, but you can't rule out these patients. This patient had sleep apnea. This patient was snoring. He had a serious problem, and he's not overweight. So you can't discount people that are not overweight as not having the problem. So you have to screen everybody in your practice. Look at those tonsils. Don't you think that they would be a problem for the airway? Look at them. There's the uvula hanging down in the middle. The tonsil on the left is called grade 4 because it completely covers the whole side. And the tonsil on the right is also covering the whole side and is also a grade 4. Now remember, there's just a little bit of opening here, but remember, we're pushing the tongue down with a mouth mirror. When you look back there, you can't see anything. There's no opening. Here's a patient I treated with Amara-Plies. You can see here that she's got a short lower face height from point A and S below the nose to the bottom of the chin menton. She can see she's got a short lower face height. She's got, you can see her maxilla is in correct position. Her mandible is deficient. You can see, when you see this little crease under the lower lip, for sure, that crease under the lower lip, you can see that she's deficient right here. So what I did is I put Amara-Plies in. I brought her jaw forward, and I increased her vertical by putting composite buildups on her posterior teeth. So look at the picture here, much better. Okay, I mean, you can see that the face height is increased tremendously. She looks much prettier. Her mandible is advanced. She doesn't have that crease under her lower lip anymore. Again, look at the picture here with that crease under the lower lip, and look at the lower lip behind the upper lip here. And here now the upper lip and the lower lip are equal, and she's got rid of that crease under her lower lip. She looks a lot prettier. Now this oral appliance, you can see right here, it has a screw at the side. When you turn that screw, the mandible advances. And remember, I told you every turn is a 1/4 millimeter. And so if you turn it 4 times, it's 1 millimeter. So that's a nice thing, and it's very comfortable. These appliances are very comfortable, and I tell the patients, look, I mean, I've had an appliance like that for about 10 years, and they do last. They're very durable. It's made of hard plastic, and it's very comfortable. Let's look at the negative effects of sleep apnea. Depression, okay? I've got some female patients who are very depressed, and they have sleep apnea because they're tired all the time. They just don't have the energy, so they get down. They just don't feel happy because they're not getting enough oxygen. They're tired all the time. They're irritable. It's just not fun for them. So if we can restore them and give them some oxygen and open up that airway and get them sleeping better, that's going to get rid of their depression. Irritability. We all know if we're tired, we're irritable. Children are irritable, we're irritable. Not a good situation. Sexual dysfunction. It definitely affects your ability to perform to your ultimate ability. That's kind of a funny way of putting it, isn't it? Let's just say sexual dysfunction. We don't have to give a big, long explanation. Most people know what that is. Memory loss. A lot of my patients are saying, you know, I've lost my memory. I can't remember things. Now, as we get older, I mean, this definitely happens more, I think. But if you're apneic and you're not getting enough oxygen and you're tired all the time, it definitely affects your memory and also lack of concentration. It affects your concentration level. And you fall asleep at inappropriate times. We're going to show you the Epworth Sleepiness Scale, and you'll see that people fall asleep at the most unusual times. And I gave you some of those earlier. And high blood pressure. So these are all negative effects of sleep apnea. These are all serious health problems, all serious considerations. So here you can see the patient's got a class 2 molar relationship, class 2 cuspid relationship with an overjet of 6 millimeters. Same thing over here, class 2 molar, class 2 cuspid, 6 millimeter overjet, plus a deep overbite. Again, a deep overbite's good because we can take the jaw and move it to here, and that's quite an opening of the airway. So the deeper the bite, the more class 2 the patient is, the easier case to treat. So again, you got an overjet of 6 millimeters. You can really see from this overjet photo that it's got a 6 millimeter overjet. And have a look, he's definitely class 2. The maxilla is here with the upper lip, and this crease under the lower lip, the most posterior part of that crease is where the mandible is. He's got a large pagonion, which is masking his class 2 malocclusion. Class 2 skeletal malocclusion. So I took an x-ray of his condyles, and I saw on the right side, first of all, the right side looks fairly normal. You can see the condyle is kind of actually downward and forward. And that's the ear right there. The black circle is the ear. And that's the glenoid fossa, and there's the head of the condyle. Now, normal condylar position is the posterior joint space from the back of the condyle to the back of the fossa should be larger than the anterior joint space. And the disc should fit right there between the front part of the condyle and the glenoid fossa, right there. So the posterior joint space should be larger than the anterior joint space, and on the right side it is. However, on the left side, you can plainly see that the posterior joint space is only about 2 millimeters, and it's supposed to be at least 4. And the anterior joint space is 4 millimeters, and it's supposed to be 2. So there's the ear. There's the condyle posteriorly displaced. Now, usually what you see in a case like that, there'd be some clicking. But he had no clicking. So that was very unusual. Normally, when the condyle's back in that position, it's an internal derangement and there's some clicking. And our joint vibration analysis would pick that up. And this is a position, he's got the Gelb 4-7 position, which I've been subscribing to for the last 35 years. And he's right, when you put the patient in that position, you rarely have a TMJ problem as long as they're not clenching and bruxing at night. So, but you won't have an internal derangement if the jaw's down and forward. So what he did is, you can see the Gelb 4-7 position. He cut the glenoid fossa in half. He cut it in half this way. And you can see he's got a 1, 2, 3, 4, 5, 6, 7, 8 little boxes. And he's found that the condyle should be basically in the 4-7 box, the 4-7 positions. Remember, the ear's back here, and the front's over here, and that's where the disc should be, and you should have a 4 millimeter posterior joint space. So downward and forward, not in the middle. You would think, well, when I graduated from dental school, they said it was supposed to be up and back. And maybe many of you have been trained the same way. The condyle is supposed to be up and back. Well, it's not supposed to be up and back because then you can't, the disc has to be forward. And the disc has to be between the two bones forward. If it's up and back, the disc has got to be out of position. And also, remember I showed you in the slide previously, there's nerves and blood vessels between the distal of the condyle and the back of the glenoid fossa. So you don't want to compress those nerves and blood vessels. So the condyle should be down and forward, not up and back. And not in the middle. I've seen some patients in the middle okay, but most patients in the middle, some patients in the middle are also having problems. So that's a very comfortable appliance. You'll see it. It'll fit right in his mouth. So there it goes. It just fits beautifully in his mouth. Now, you have to wear these elastics. They're called class 2 elastics here and a vertical elastic here. So from there to there is a class 2 elastic, and from here to here is a vertical elastic. You must wear those elastics or it won't work. He'll come out of his appliance. So then we do the pharyngometer. As we always do in all our patients, we want to establish what the normal airway is and what the collapsed airway is. So remember, here is the mouth. There's the opening of the mouth, and that's why the line is so high here at 6. And there is the size of the airway. So remember, the green line is the size of the normal airway. Okay, so the normal airway is 1.69 square centimeters, but normal for a male is 3.2 square centimeters. So his normal airway, not the collapsed airway, his normal airway is half the size it's supposed to be. So this could be a problem. This could be a problem with the oral appliance because his normal airway is not even close to the right size. Then we look at the collapsed airway. Okay, in the collapsed airway, you can see the collapsed airway is the pink line down here. The lower line here is the pink line. The collapsed airway is 1.01 square centimeters. So the collapsed airway is 1.01 square centimeters and normal is 2. So again, the collapsed airway is half the size of the normal airway. So its normal airway, the green one, is half the size, and the collapsed airway is half the size. So then we put the jaw in different positions. We try to put the jaw in different positions to see if we can open up the airway. Well, we put them in different positions. We could not show an increase in the airway. Okay. So we tried to open the patient 7 millimeters and 2 millimeter overjet, and the airway went to 0.80, which is a reduced airway. The airway was 1.01, and then with the bite, when we put the jaw in different positions, the airway did not increase. So if we do that, I would not think that the oral appliance would be effective unless we put something to depress the tongue. So when I see this happen, I immediately think tongue depressor. I have to put something to push the tongue down. Remember, oral appliances work nicely by bringing the jaw forward. Okay? They work great doing that. But they also, if you've got a high tongue position, you've got to push that tongue down. So we do a joint vibration analysis. Highly recommend you get this equipment if you're going to treat any patient. You have to diagnose the presence or absence of temporomandibular joint dysfunction. If you're going to be putting these appliances in patients, you have to evaluate the TMJ like I did, give them that TMJ health questionnaire form, and it'd be nice to have this JVA. It's like $250 a month on a lease. It's not a lot of money to know exactly what's going on with all your patients. You get that BioResearch in Milwaukee. Okay, joint vibration analysis. So you can see over here that the noise level was from 0 to 20. And so what we do, we put the transducers over the TMJ, 2 little microphones over the TMJ. The patient opens and closes 6 times. You record all the vibrations. 1, 2, 3, 4, 5, 6. And the average of all the vibrations on the right was 8. You try to get below 20. Noise is bad in any joint, including these joints. And on the left is 11.8. So we do a little formula, which we've done before for you in this course. And the noise levels from 0 to 20. The patient can open 43 millimeters, so we go 40 to 70. How much is over 300 hertz? It goes right here, 1.8. That's between 0 and 5. So you come down here as normal. Not very difficult to figure out. The staff do this for all my patients prior to me seeing the patient. So we take a Ceph on everybody. It comes from my background in orthodontics because I want to check the airway. Now I always check for adenoids, and adults don't normally have large adenoids. I don't think I've seen an adult with large adenoids. I've seen adults with large tonsils, but not large adenoids. So we come across at the hard palate, measure the airway from here to here. Right there. That's where the adenoids would be. They'd be right over here, and they're not there. And then we come across the lower border of the mandible to go from the angle of the mandible to the posterior pharyngeal wall. That's the lower pharynx, and that airway looks pretty good. So he doesn't have any blockage of the airway. No tonsils, no adenoids at least. And he's got a 4 millimeter overjet up here, and a little bit of a retrognathic mandible. So that's favorable. Now, oxygen desaturation, very important. Okay, so you need to look, and that's why I like this in blood asleep study, because it talks about oxygen desaturation. You know that the blood oxygen level should be around 95 or 97%. Okay? The average oxygen saturation is 95.7, so that's very good. He's desaturating 24 times. He's desaturating 24 times. It's going down below where it should be. Let's look at the apnea-desaturation relationship. Okay? Remember, you like to be above 90. 95, 97 is the best. And his average, it says here, was 95.7. So that's excellent. Okay, so he desaturates above 90 10 times. So he's supposed to be 95. He goes down down 4% or more 10 times. And he goes below 90 twice. So that's not bad. So above 90, he's having 10 events. Below 90, he's having 2 events. That's really good. I mean, that I would not be worried about him having a heart attack or a stroke or getting diabetes or any major health problems based on his apneic events. I would say he's in pretty good shape. He's I mean, that's an excellent result. We'd have to go back and look at his other sleep study to see how much he was desaturating originally when he didn't have a CPAP and didn't have his oral appliance. But for sure, with the oral appliance, he's doing quite well. You want to make sure they don't desaturate. You have to control the desaturation. The oxygen desaturation, when the oxygen level goes down, the blood pressure goes up, and that's when you get into all kinds of problems. So this is after insertion of the oral appliance. What we try to do is we want a reduction of the snoring. We want a reduction of the other symptoms such as daytime sleepiness, reduction of gasping for breath, and reducing the RDI by 50%. So those are kind of the criteria that we follow to, and I will discuss RDI with you in a little while. RDI is very similar to AHI. RDI means Respiratory Disturbance Index, and AHI, as you know, means Apnea-Hypopnea Index. So I'm going to go over those with you later. But what you'd like to do with the oral appliance is reduce the HI or the RDI by 50%. That's considered normally a successful case after you titrate the appliance. So we're trying to reduce the snoring and the daytime sleepiness and the gasping for breath and the obstructive sleep apnea. The SomnoMed appliance, as you can see right here, is probably my favorite appliance. It's a 2-piece appliance, and you've got a side screw here on both sides. So it's extremely important to put the appliance in and make it comfortable. If it's not comfortable, the patient won't wear it. That's why patients prefer oral appliance to CPAP devices, because CPAP devices, a lot of patients don't find them very comfortable. Again, if I had to make a statement regarding acceptance of CPAP devices versus non-acceptance, I would say that the patients that are severe sleep apneics really do seem to adapt to their CPAP devices much better than patients who are mild to moderate. So I think that's why we really need to have oral appliances in the mix. As you know, there's 3 treatment options for obstructive sleep apnea. Number 1 would be CPAP for severe cases. Number 2 would be for mild to moderate cases, oral appliances. And number 3 would be the surgical intervention. I'm going to be talking about all of those today. So that's a SomnoMed appliance. I'll be describing that in more detail later on, but it's basically a 2-piece appliance. And I prefer a 2-piece appliance so the patient can open and close, and it has to be adjustable or titratable, which means that if you make the appliance and the patient's end-to-end, and they're still snoring and they still have sleep apnea, you're allowed to advance the mandible, or you're able to advance the mandible by turning those side screws slowly, and each turning of the side screw is a 1/4 millimeter. You turn it, say, twice a week, and so the patient gets 2 millimeters a month advancement of the mandible. But we'll discuss that in a little more detail when we get to the SomnoMed appliance. Here's another patient wearing a CPAP device, a different device. There's all kinds of different designs. There's so many different designs, and the DME companies, the companies that will provide your patients with CPAP devices, they have all kinds of different designs. They usually will allow the patient a month to try the appliance before they have to pay for it. Many times insurance companies will help the patient pay for the CPAP devices. And in some cases, insurance companies will even help dentists through medical get paid for the CPAP devices. I recommend that you use Rose Neerman, and I've recommended her earlier as part of this presentation as someone that you want to contact. And so her name is in this presentation. You can find her, Neerman Practice Management, you need to contact her, and she can provide you some forms and some expertise and on how to collect from insurance companies. So this is another type of CPAP device that the patient looks quite comfortable wearing. There's no head strap. It would seem to me, though, when the patient moved to the side, that might come off. So maybe that's a disadvantage of that particular model. This is a modified Herbst appliance. This came out of UCLA. Dr. Glenn Clark is the founder of this appliance, and that's also an excellent appliance. It's a two-piece appliance. The patient can open and close. What I really like about this appliance, it is adjustable. It's not showing here, but you can add little shims, 0.5 millimeter, 2 millimeter shims if you want at the side, and slowly advance the mandible. So it's totally adjustable that way. You can increase the vertical again by adding acrylic to the lower part of the appliance. Again, 2 plastic trays, 2 clear trays. And the thing I really like about this appliance is that it's got this elastic here. So for patients who try to open too wide and fall out of their appliance, you've got these elastics holding it together. So this is also a very comfortable appliance and a very popular appliance for some patients. So that's a nice one. And this particular form here is kind of similar to the Epworth Sleepiness Scale. But it talks about snoring loudly daily and choking when she's trying to, struggling for breath. She's awakened repeatedly because of the breathing problem. She's tossing, turning often. She's got dry mouth. She feels tired and unrested. You know, she frequently falls asleep when she's watching TV. She's got daytime sleepiness. And down here are some medical situations. And how long has she been snoring? A long time. Have relatives complained? Sometimes. Have you been told you stop breathing when you're asleep? Yes. Have you told you move around a lot when you sleep? No. She sleeps mainly on her side. She wakes up 3 times a night. Well, what happens is these patients are having these arousals. Okay, so that's stimulating the bladder, I believe, and that's why they have to wake up and they have to go to the washroom 3 times. So she's waking up 3 times, which is not good if you're waking up all the time. I think if you wake up once, that's kind of normal, but if you wake up 3 or 4 times, that's not normal. Difficulty falling asleep? No. Remember I told you, patients with obstructive sleep apnea, they hit the pillow, they're gone. They don't have any problems with falling asleep at night, but they have trouble staying asleep. She wakes up 3 times. How many hours do you sleep per night? She gets 6 hours. Probably she should try to increase that to at least 7. I would recommend that she try to get 7 hours sleep. Does she, and this is one of the most important questions. Do you wake up feeling refreshed? No. Never ask a patient, how do you feel you slept last night? Oh, I was in bed 6 hours, I felt fine. I slept fine. No, don't tell them that. Ask them, did you wake up refreshed? That's the key. Did you wake up refreshed, and during the day, do you get tired? Those are the things you need to ask them. Do you wake up with a headache? No. Well, if she wakes up with a headache, frequently patients who brucks and grind at night, they wake up with headaches. She's not waking up with a headache. Does a small amount of alcohol give you a headache? No. Do you feel sleepy during the day? She says occasionally. Now that's really surprising. She doesn't wake up refreshed, but she doesn't feel as sleepy during the day, and her Epworth was only 7. Okay, so she mentioned who she went to for sleep studies. And she went to an ENT specialist, and she went to a sleep specialist. She's had a sleep study done. Doesn't have any difficulty breathing through her nose. Look, she's 138 pounds, 5'7". I mean, she's in good shape. Her blood pressure, she's taking medication. Okay, so she's acid reflux, Nexium, medication, high blood pressure, medication, but it is being controlled. Because we take her blood pressure, it's 130/75. So that's good. That's a normal blood pressure, but she's being controlled with medication. Do you have any loss of memory? No. Any depression? No. Does your jaw click? Yes. It never locks though, so that's good. And so she signs it. So we give them the Epworth Sleepiness Scale when they come in for their initial appointment. Okay, the initial appointment. Now, in your general practice, what I recommend you do, give everybody the TMJ health questionnaire form, and if they answer, do you snore at night, then you give them the Epworth Sleepiness Scale. And then you say, look, I think you snore at night, you filled out the Epworth, I think we should book you for a sleep study. So book them for a sleep study and then bring them in for records. When you have the records taken and you've got the sleep study from the hospital or this private sleep clinic, you have that, then you bring the patient back and you do a consultation appointment and tell them what your treatment plan is and what the diagnosis is from the sleep specialist. Anyway, I hope you enjoyed the case. I thought this was a very interesting case. Thank you very much.